Right? So let's go on then. So the first talk of this morning is on the principles of neurosurgical education. Dr. Federico Di Rocco, who was my co-chair for the ISPN Education Committee, felt that this was an important topic that we should discuss. And increasingly, more and more institutions are training educators, not just to train medical educators, but also surgical educators. There are many universities now that have trained medical educators. Surgical education is slowly becoming something that's also being considered. Right? So I'll talk about it. And what's the purpose of surgical education? There's a paper from The Lancet that says, well, the purpose of medical education is to promote health and to reduce the burden of suffering diseases. And likewise, the ultimate purpose of surgical education is to promote competent surgeons who, through their surgical craft, are able to reduce the burden of suffering and disease. And so then we ask ourselves, well, how do we train our neurosurgeons? What do we want our neurosurgeons to become? Obviously, we want them to be competent, to be safe, to be independent practicing specialists, to care for patients with neurosurgical disease. And that's what we're all here. But there's also another thing. Being a neurosurgeon, you are actually a member of a team. You're not just a single person looking after the patient. So you have to learn also in the training to be a member of multidisciplinary teams. And this could be working with the anesthetists, the ICU intensivists, nurses, therapists, and so forth. And of course, what we want our young neurosurgeons to do is to take over our jobs and be the neurosurgical leaders of tomorrow. And finally, to be lifelong learners, because neurosurgery, like any science, is a progressive specialty with new changes coming in. Today, we'll discuss some of these changes that will affect how we look after the patients that we currently have. So lifelong learning is a very important aspect, and we want to teach our young doctors to continue to learn so that they can continue to put up the best for our patients. All right? If you look at past training, and even to some extent current training, the keyword is see one, do one, and then you teach one. All right? That's how many of us actually train. All right? And the training that we have is a form of apprenticeship. We go and join a department, we work our way through, and we practice and learn as we go along. And then one day, either we pass the exam or the boss says, okay, you're ready to become a consultant, and then you become a consultant. Okay? The current training in many centers now is the use of a curriculum. All right? Most training centers actually have curriculum, but the important thing is the curriculum training towards competency. And so we ask, what is competency? Can resident X successfully carry out task Y in all relevant aspects of the task? And this includes not only the ability to perform the surgery, but also the necessary knowledge, the attitude, and the will to carry it out in circumstances and with the available means. And that's actually a very generalized thing because different units have different ways of managing because of economic issues, costs, and so forth. Right? You, as the resident, they have to actually know and get adjusted to it. Now, when we look at competence, and this is a Miller's triangle which talks about performance and how good you are, actually the competence is only here at this level. Right? It is not actually, the behavior that they practice. So we train our residents to be competent, and as they carry on training in practicing neurosurgery, then they develop the higher professional competence as they go along. All right? And some of these competence are basically also involved in the various aspects of the training and how you become a surgeon. So the Canadian Medical Roles Framework looks at a surgeon being a professional, a communicator, a collaborator, a manager, a health advocate, and as well as a scholar. And this is a graph from one of the medical educators talking about a relationship between professional activities and competent area. This is actually a way of testing and assessing doctors whether they are skilled in these areas. Now, EPA stands for the it's the words just missed my mind. But basically, it's actually entrustable professional activities that you actually get your young doctors to do. So here they start about performing a venipuncture, doing a electrical cardioversion. So in neurosurgery, we will start to entrust certain activities to our trainees as soon as we think that they're ready, and then we assess them to see whether they're ready or not. Another area that is getting in the US, right, the accreditation for graduate medical education, all our residents, because in Singapore now we follow the ACGME residency program, and so all our residents have to be seen to develop and become proficient in these 6 competencies, which are patient care, medical knowledge, practice-based learning and improvement, system-based practice, professionalism, and interpersonal skills and communications. You would find that actually in many of our trainings, the first 2, right, patient care and medical knowledge, we do very well. It's the other competencies that we may not do very well. Right. So, although technical proficiency is definitely an important prerequisite for a successful outcome, other qualities such as intellectual abilities, personality and communication skills, a commitment to practice are important elements in the profile of a competent surgeon. Right? So training a surgeon is not just training him to cut, there are other skills that he needs to learn along the way. There's a very interesting article which was published by Atul Gawande, and he was actually a resident at the time, and he was actually invited to give the J. Roland Force lecture, invited lecture, and he talked about creating the educated surgeon in the 21st century. So he asked, when we talk about good surgeons, what we mean, what are they? So he says that they are surgeons who can provide humane care with the best possible results, and that there are 3 technical components: technical skills, safe judgment, and a high moral performance, right? Meaning conscientiousness and dedication. He also agrees that medical science and technology is just too vast to train everyone to do everything. And he says that the problem with surgical training tends to overemphasize operation surgery over disease management. And this leads surgeons to cling to purely technical procedures that could have easily been given up to technicians. For instance, when we first started, we were trained to do central venous lines, of course. Today, there are actually technicians in the ICU who will do this, all right? And interestingly, he actually, in that paper, he showed that there were 2 models of training, the breast surgeon and the neurosurgeon. And he says that the breast surgeon sticks with the traditional operative paradigm. Residents learn primarily to master surgical techniques, so they do biopsy, axillary node dissection, mastectomy, and to make decisions about who deserves which of them. But because breast cancer is something that actually has, the knowledge has expanded vastly, right? They now require the use of other more various technologies such as hormone therapies, genetic diagnostics, new chemotherapies, node biopsies, and so forth, percutaneously, and radiological techniques that the breast surgeons do not practice or even learn. And so they leave it to other people to do, right? And so that's the breast model of joint multidisciplinary care of cancer patients. And he takes his place alongside the oncologists, radiation therapies, radiologists, and so forth, right? And the problem is that here, the breast surgeons are specialists of a technique, right? With the resulting risk that they become mere technicians, and they are slowly playing a diminished role in what's the best approach for a patient, okay? The neurosurgery model, he says, is a bit different. Neurosurgical trainees are taught first and foremost to be experts of neurosurgical disease. So we know everything about brain tumors, we know about cerebellar aneurysm and so forth. And we rotate to neurology, neuroradiology. Right? We learn a variety of techniques, craniotomy, stereotactic radiation, intrathecal chemotherapy, MRI-guided radioablation. Whatever the department has, you learn those techniques, including endoscopy. Right? And so this training allows us to become advocates, not of techniques, but of the best therapy for the patient's disease. And so whether it's today or in the future, if a patient has a brain tumor, the neurosurgeon should be able to direct the patient to the full range of management. It is true, even in oncology today, we have multidisciplinary clinics that decide on treatment. But as the neurosurgeon, you know what they are going to say, and you can prepare yourself and your patients for that. Okay? And this was in 2001 when he wrote that paper. So imagine 15 years down the road. What now are we now? Are we still training neurosurgeons using the neurosurgery model? Yes and no, depending on where you are. But I'm quite sure that sometimes we are getting too technical because we like to look at the skull base, the aneurysm, the vascular thing, because they are very sexy, right? So surgical training should match as best as possible eventual surgical practice. So what are you going to do? So if you're going to work in a place where there are no super specialists in neurosurgery, you have to learn to do everything, all right? You be efficient and exclude irrelevant training, redundant training for other things. You need to be broad and substantial enough to support the requirement of lifelong retooling and be sufficiently attractive to prospective trainees. And that's the other problem. We may not be getting trainees who understand very much about neurosurgery. They just want to do the sexy stuff, okay? So that's about training. So what are some of the things that we can do to actually make surgical education better? Right, there are a few things that we have talked about, which are some are theories, some are very practical. In surgery, the area of learning theories that are important is feedback and reflection, deliberate practice and expertise, threshold concepts, and then situated learning and communities of practice. Now, these are theories, and they are about learning, all right? And they are not the same as the type of concrete evidence that we look for whenever we look for evidence in our clinical practice. In fact, they emerge from many disciplines such as education, psychology, sociology, philosophy, and anthropology. And so there are empirical versus conceptual theories in education theories, right? And what we need to understand is the way we learn science, we are either positivism or post-positivism. It means that reality can be considered as an objective truth. You need to show the evidence. If the evidence is shown, we believe in it. The problem with education theory is you're going on to the other side, either the interpretivism or the critical theory thing, where it's more woolly, it's not based truly on scientific evidence. And that sometimes can make it very difficult for us to appreciate that. So one of the theories is constructivism, which is based on the idea that the individual, as an individual, how do you learn? You store knowledge and understanding in unique ways, and that knowledge that you have in you will in turn influence your recall and understanding when you have new knowledge and how you create new knowledge. So it's the knowledge that you have is stored in some form of schemata that can be more or less complex, but it interconnects with each other and is influenced by a number of factors. And as you gain new knowledge and understanding, you actually add and you change the existing schema in your brain. I mean, that's quite logical. And the application here is that when you teach, right, the knowledge can be and learn, the knowledge can be better retained and accessed when it is learned in a context that and has been linked together during learning. So basically, you learn in the context, and then that's where you actually improve your knowledge because you appreciate and understand better. Okay? Feedback is a very important aspect of learning. Information in actually machine, there's machine feedback, and that's the information in the system that used to make adjustments so that they can achieve a goal. All right, and you control that system by reinserting in the system the results of the performance, and that's actually feedback. Right? That's mechanical feedback. In the clinical setting, you refer to information describing the trainee's performance in a given activity that is intended to guide. So as a feedback giver, you tell the trainee, are you doing good in this? You're not so good. Why you're not so good? Right? Of course, you don't go into the personal aspect. Then the other part is reflection. Right? It's, and reflection actually is based to a certain extent on this corpse learning cycle where, so let's say you do a surgery, right? You did something, then you reflect on the surgery. Did I do better? Could I have done even better here? And then you say, well, the next time I do this surgery, maybe I should do it this way. And then you try it out. It works. So you have the abstract conceptualization, and after you try it out, it works. So then you have that concrete experience. And so it's a learning cycle. Right. I've been cut off. So basically, there are actually several theories learning that actually can help us to improve the way we learn. Right? Another part that I was supposed to touch on is deliberate practice, where in theory you're supposed to spend 10,000 hours to perfect a certain skill. Now that's for golfers, that's not for surgeons, because neurosurgery is much more complex than just hitting a ball. Right? But the more we learn, the better we get. So I thank you very much for this opportunity.